Good afternoon. Welcome to Parkinson's Social Network. My name is David Baum. I'm a member of the PSN board. And today, PSN is proud to prevent cardiovascular signs, symptoms, and risks associated with Parkinson's disease. Our mission as an all-volunteer organization is to support, advocate, educate, and enrich the lives of those touched with Parkinson's disease. We have various online resources throughout our website and our YouTube channel, and virtual events such as today's. For those of you who don't necessarily know how to contact us, our website, email address, and our phone number are shown here. We answer our phone almost every day of the week at various hours of the day, but we always get back to someone if you leave a message, if we shouldn't be in at the time. We'd like to remind you of some housekeeping. We'd like you to remain muted at all times. Please place any questions that you may have in the chat feature. The questions will be given to our presenter at the end of the presentation to give, in this case, Dr. Levy, the opportunity to answer your questions. As a reminder, today's presentation is being recorded, and it will be placed in our YouTube channel. And we'd ask you to remember that today's presentation and the information that PSN provides in all of our activities is designed to fulfill part of our education mission, and that it's very important that you realize that these are not provided as a substitution for proper consultation with and obtaining advice from your own personal medical healthcare provider, because that individual is the one you should be dealing with because they understand your specific situation. Today's presenter is Dr. Warren S. Levy, who is a board-certified cardiologist. He has a special interest in coronary artery disease and risk modification, especially through exercise and weight reduction. Dr. Levy is the immediate past president and the immediate past chief medical officer of Virginia Heart. He earned his medical degree with honors from George Washington University School of Medicine, where he also completed his residency and his fellowships in interventional cardiology. At this point, I'm going to turn the meeting over to Dr. Levy.
Again, thank you for inviting me. I'm Warren Levy. I'm a cardiologist with Virginia Heart, as well as an Overshire Heart and Vascular. And I appreciate the opportunity to talk to the group. And what I plan to do here is go through some stuff. I'll probably speak for about a half hour or so. And then if questions come up along the way, please just put them in the chat and we'll try to run through those at the end. What I hope to talk about is basically the major cardiovascular manifestations of Parkinson's. We'll talk a little bit about the autonomic nervous system. We'll talk mostly about orthostatic hypotension, since that is sort of the major cardiovascular manifestation. But we'll also talk about other blood pressure issues associated with Parkinson's. We'll talk a little bit about how some of the medications that are used for Parkinson's can actually make some of the cardiovascular symptoms a little worse. And then we'll talk about other cardiovascular issues that are associated with Parkinson's, who and when who should see a cardiologist, and then what type of surveillance would be appropriate from a cardiovascular perspective for patients with Parkinson's disease. So let's see if we can get these guys to move. Good. So as you know, I don't need to tell you that Parkinson's disease is a neurodegenerative disorder characterized mostly by motor symptoms such as tremor, rigidity, bradykinesia, difficulty, slow movements, and postural instability. The non-motor symptoms, including cardiovascular dysfunction, are common, but are often not recognized and are often present prior to motor symptoms that bring patients to attention, at which time they're diagnosed. The cardiovascular symptoms can be very disabling, and they can affect the quality of your life and may contribute to both morbidity as well as mortality in certain cases in patients with Parkinson's disease. And understanding this helps us better manage it, better try to control the symptoms, and hopefully improve both quality of life as well as patient outcomes. So the autonomic nervous system, and I'm not going to get into a whole autonomic nervous system talk, but the autonomic nervous system is the part of our nervous system that you have no control over. It's your autopilot, if you will, and it functions on its own. That's why it's autonomic, and it controls many, many functions in our body. You don't have to think about breathing. You don't have to think about your heart beating. You don't have to think about controlling your blood pressure or a myriad other number of bodily functions. But the ones I want to sort of focus on here on this little chart are the ones that are pertinent to our discussion today about Parkinson's disease and the cardiovascular manifestations of Parkinson's disease. So on the left side, you see that that's your sympathetic nervous system. That's the part of your nervous system that will increase your heart rate, that will increase contractility, that will increase vasoconstriction, meaning constriction of your blood vessels in your body to raise your blood pressure. Think of it as that's kind of your fight or flight kind of side of your autonomic nervous system. On the other side is the parasympathetic nervous system, and that's kind of the relaxed, chill side of your autonomic autopilot. It decreases your heart rate, it decreases the contractility of the heart, and it relaxes the blood vessels in your body. And this is what doesn't function normally in patients with Parkinson's disease. So normally, how do we control our blood pressure? And how do we control our blood pressure, especially as it relates to gravity? So I'll probably repeat this at the end, but I will just tell you that gravity is not your friend, right? Gravity keeps our feet on the ground, but other than that, it presents certain challenges to our body, to our physiology. And sort of the example is if I would take a long tube of a fluid and I would hold it flat, like it's laying on a bed, all that fluid would be distributed equally in the tube. But then when I'd stand it up straight, all the fluid would go to the bottom because of gravity. And in fact, that's what would happen when you go from a supine position or laying down and transition to an upright position. What would normally happen is all of your blood would then start to settle into the lower part of your body. And in fact, when you do that, some of your blood does settle into the lower part of your body. But under normal physiologic conditions, we have automatic compensatory mechanisms that kick in to keep our blood getting back up to our heart and up to our brain so we don't pass out. If we didn't have these mechanisms, we'd be a very interesting species that every time you stood up, you'd pass out and then you'd be laying down again. So we depend on our autonomic nervous system to automatically kick in these compensatory mechanisms of increasing vascular tone, increasing heart rate, increasing contractility to maintain a normal blood pressure regardless of our orientation as it relates to gravity. So what is orthostatic hypotension? Well, number one, it's the most common cardiovascular manifestation of Parkinson's disease. Orthostatic hypotension is found in about 50% of patients with Parkinson's. It's defined as a greater than 20 millimeter of mercury fall in your systolic blood pressure, or that top number of your blood pressure, or a greater than 10 millimeter of mercury fall in your diastolic blood pressure, which is the bottom number on your blood pressure. And as I said, about 50% of patients will have this. Now, it won't always be severe enough to cause symptoms, but it will be present. It's due to, as I said, the impaired sympathetic outflow. Remember, sympathetic versus parasympathetic, that's the increased squeeze, increased heart rate, increased vasoconstriction, reduced release of norepinephrine into your bloodstream that we need to do in order to maintain our blood pressure when we move against gravity. We also have a bunch of, our body is really cool, by the way, and whoever engineered it was really brilliant, but we have these baroreceptors in our body. We actually have these blood pressure monitors in our body, in our carotid arteries and in our kidneys, that monitor blood pressure and cause the autonomic nervous system to do certain things to control our blood pressure. And in Parkinson's, you also lose some of that those baroreceptor reflex functions, exacerbating this condition. The symptoms of orthostasis or orthostatic hypotension are dizziness, lightheadedness, blurred vision, syncope, meaning fainting, passing out, fatigue, diaphoresis, that's that cold sweat you sometimes feel. I'm going to go through these, I think, on another slide. And it's really pretty easy to diagnose. It really just involves measuring blood pressure, laying down, sitting up, and standing up. And if you have that greater than 20 millimeter drop, you have orthostasis. We used to do things like these tilt table studies in the past, and some of you may have heard about those. We try not to do those anymore. They don't really increase the specificity of the diagnosis, and there is some risk associated with that. And then we're going to go into the management of orthostasis as well, which basically has three components to it, and I'll move forward in a second. So cardiac orthostatic hypotension is what we call cardiac dysautonomia, meaning the autonomic nervous system is not controlling cardiac function as it should due to autonomic nervous system malfunction, and it's the most prevalent cardiovascular manifestation of Parkinson's. It's not only, this is important too, it's not only with gravity. So it's not only orthostasis or orthostatic hypotension, it's also postprandial. So postprandial means after you eat a meal. And the reason for that is after you eat a meal, some of your blood supply is kind of diverted to the abdomen, to the splanchnic bed. And again, the autonomic nervous system in people who have normal physiology will say, okay, more blood to the GI tract because we need to digest, but we're going to kick in some compensatory mechanisms to keep the blood pressure up. In Parkinson's, the body can't manage that change in blood flow, and the blood pressure will fall after meals as well. That's important to remember, because if you have orthostatic hypotension or orthostasis, you know that you need to move slowly against gravity. You can't jump out of bed and stand on your feet. But you also need to be aware that after a meal, you're going to be especially prone to a drop in blood pressure, and you need to be especially careful. As I mentioned, these symptoms can be present well before the motor symptoms show up. So patients who have this symptom, hopefully will seek medical attention, and it could be years before any of the motor symptoms manifest themselves and you come up with a diagnosis of Parkinson's. Obviously, the risk of orthostatic hypotension is that, number one, you can fall down and hurt yourself, break bones, break hips. You can pass out and really hurt yourself, but also patients tend to be afraid to go out, and it can lead to social isolation. We talked about the dysfunction of the sympathetic and parasympathetic nervous system. We talked about the definition, and we talked about how 50 to 60% of patients will actually have it. The signs and symptoms, we mentioned, again, they can be very mild, like, that momentary feeling like the rug was pulled out from under my feet when I stand up, but then I'm okay, to breaking out in a cold sweat, to feeling very pale, to having a loss or a graying out of your vision, or a tunneling of your vision, feeling very lightheaded. You can feel like you need to move your bowels, and it can even lead to seizures if your blood pressure falls low enough. So how do you treat it? What do you do for it? Well, as I said, there are three phases, or three arms to treatment of orthostatic hypotension. The first is you want to try to remove anything that's making it worse. And that would mostly be medications. So there's a whole slew of medications that can make orthostasis worse. Unfortunately, some of them are your mainstay medications for Parkinson's disease. We'll talk about that in a minute. The second is what I call conservative therapy. And a lot of patients get away with conservative therapy. And that is basically drinking lots of fluid, support hose or abdominal like girdles, not moving quickly against gravity, exercising in a supine position, et cetera. We'll go through some of those. And then the third are medications. And there are a few medications that can be very helpful in the setting of orthostatic hypotension. So medications that can make orthostatic hypotension worse. I'm going to go through, I think, a whole list here in the next slide, but certainly diuretics. Most of the blood pressure, if you have hypertension, most of the blood pressure medications will make it worse. Levodopa is the medicine I was alluding to, sort of a mainstay medication for Parkinson's. It also exacerbates orthostatic hypotension. Some of the other Parkinsonian medications can also do this, as well as lead to other cardiovascular issues. Now, I'll mention one of the problems is that in Parkinson's, not only can you develop orthostatic hypotension, but you can also have what we call supine hypertension, meaning when you lay down, your blood pressure gets exceedingly high. And so you can understand this can be a double-edged sword. You have someone who has exceedingly high blood pressure when they're laying down, you want to treat it, but then a lot of the medicines you're going to use to treat it can make the orthostasis worse. Some of the, I know this is a busy slide, maybe hard to see that, but a lot of the medications that exacerbate orthostatic hypotension. And by the way, I sent these to David, and he's free to distribute the slides. So if you want to request the slides from David, or however he wants to do that, you can get a copy of these. So don't worry about it. But certainly any of the diuretics that we often use for high blood pressure, the alpha-1 adrenergic blockers like camlodipine, or beta adrenergic blockers, beta blockers, which are extremely common medications in cardiology, will exacerbate this. Any of the nitrates, nitroglycerin, as well as the phosphodiesterase inhibitors, the Viagras and Cialises of the world, will really exacerbate orthostatic hypotension. Your ACE inhibitors and angiotensin receptor blockers, for sure, calcium channel blockers. We talked about the dopamine antagonists, some of the antidepressants and the SSRIs. There's a whole litany of medications that can make orthostatic hypotension worse. So the conservative therapy we talked about, this is the only time you'll hear a cardiologist say this, by the way. You want to take in more salt. I'm normally telling my patients to decrease their sodium intake, but for orthostasis or orthostatic hypotension, you want to increase your sodium intake because that helps to keep your intravascular volume up. You want to keep the tank as full as possible so that when you move against gravity and some of that fluid shifts to your lower body, you've got more of it around so it doesn't drop your blood pressure as much. So you're going to take in a little bit more salt every day. You're going to be drinking lots of fluid. Anyone who has orthostatic hypotension, when they come and see me in the office, if they don't walk in with a water bottle in their hand, they get yelled at. You want to obviously be very careful about moving quickly against gravity. You want to avoid isometric type straining exercise. You want to try to get exercise, but you're better off doing more recumbent or supine exercise, because with exercise, you're also at risk immediately post-exercise of your blood pressure falling precipitously and passing out. And then we talked about an abdominal binder. We do talk about support hose. I try to get people to wear thigh-high support hose. That can help a little bit. But this is what I call conservative measures. Medications, the two medications that I tend to use most are midodrine or proamotine and Florinef. The midodrine is an alpha agonist that tends to increase vasoconstriction and holds blood pressure up. Now, if any of you are on midodrine, you need to understand that this is a very short-acting medication. And I see a lot of people make a mistake who are taking midodrine for orthostasis. They say, well, it's told to take it twice a day, so I'm taking it like with breakfast and dinner. That's not what you do. You need to take it like 4 to 6 hours apart. So you take it early in the day and then midday, because it's a very short-acting medication. And in fact, it can be taken 3 times a day because it's so short-acting. You want it to be active during your daytime hours when you're erect, and it doesn't matter when you're going to bed at night. Florinef is a mineralocorticoid. It basically works at the level of the kidneys to have you retain more fluid and keep the tank full. So those are the two mainstay medications that we use for orthostasis. As I mentioned earlier, one of the paradoxes here is that even in the setting of orthostatic hypotension, it's very common in Parkinson's to see supine hypertension and what we call nocturnal non-dipping. It's a funny term, but supine hypertension just simply means that when you lay down, your blood pressure goes way up, which is the opposite of what it should be. It's paradoxical. Again, that's secondary to autonomic dysfunction. And it's unopposed sympathetic tone when laying down. So it's really sort of that dysfunction more of the parasympathetic nervous system than the sympathetic nervous system. But it can also increase the risk of cardiovascular events, especially during sleep. So people can have real hypertensive crises when laying down when they have this supine hypertension. Management involves medication, involves sleeping in a somewhat upright posture at about a 45-degree angle, as well as some of those short-acting medications that I told you have to watch out for because they can lower your blood pressure. Nocturnal non-dipping is it's sort of more a curiosity than anything else. Normally, when you go to sleep at night, your blood pressure and your heart rate fall. That's just a normal physiologic response, right? Nocturnal non-dipping, you lose that circadian rhythm of heart rate and blood pressure. And it can be, there is a strong correlation with cardiovascular illness as well. So what other cardiovascular problems do we look for or are we concerned about in the setting of Parkinson's disease? Well, one of the problems with this, and it's always hard when you have multiple variables you're looking at, is that the demographics of Parkinson's and heart disease can be very similar because it does tend to occur in older men, and we have a lot of cardiovascular disease that occurs in older men. It's more prevalent in patients who have hypertension and diabetes, both Parkinson's and cardiovascular disease. So there's a lot of overlap there. But there have been a fair number of studies that have drawn a correlation between Parkinson's disease and ischemic heart disease and heart attacks and strokes, with valvular heart disease, and some of the Parkinsonian medications have been shown to increase the risk of valvular disease as well, both what we call systolic and diastolic heart failure. Systolic heart failure is when your heart muscle becomes weakened and isn't squeezing very well, and fluid and pressure backs up into your lungs and into your legs, and you have trouble breathing. Diastolic heart failure is when you have a very strong, thickened heart that's squeezing very hard, but it just can't relax very well. And so it can't fill with blood between each beat, and it actually backs up the pressure and fluid as well. So two different ends of the spectrum, but both can lead to heart failure symptoms. And then heart rhythm abnormalities, and some of that can be attributed to some of the medications that can prolong what we call QT interval. And there are certain medications that you need to be monitored in terms of your electrocardiogram to be sure you're not developing any of those issues. So real quickly, let me just run through those topics, and I'm not going to give an entire talk on each of these abnormalities, but just a quick overview. So when we talk about ischemic heart disease, we're talking about basically coronary artery disease, peripheral artery disease, carotid artery disease. And what that is that's a buildup of plaque, of junk, inside any arteries in your body. They can be inside the arteries that supply the heart with their blood and oxygen, the coronary arteries. It can be within the arteries going up your neck into your brain, the carotid arteries. It can be the arteries leading to your kidneys or to the legs for peripheral arterial disease. And that is a multifactorial kind of risk profile. But again, a somewhat increased risk of developing ischemic heart disease or vascular disease in patients with Parkinson's. I mentioned, oh, a typo. It's valvular heart disease and not heat disease. But as I mentioned, some of the medications used for Parkinson's, like bromocriptine, can lead, and we don't know why. We don't know the mechanism of this. We just know that there is a statistically significant correlation between the use of these medications and the development of valvular problems of either the mitral or the aortic valve. The mitral valve is the valve between the left atrium and the left ventricle, which is the blood coming back from the lungs, which is oxygenated, that then goes to the main pumping chamber of the heart, or the aortic valve, which is the valve between the main pumping chamber of the heart and the main artery leaving the heart, the aorta. And again, there's a lot we can do about this, but we need to recognize it before it occurs. We talked about systolic and diastolic heart failure. And again, it's not exactly clear what the mechanism is, what is actually leading to this, but there is an increased risk in patients with Parkinson's disease to develop either of these forms. Especially diastolic heart failure would be much more common in patients with high blood pressure who have really severe supine hypertension, because hypertension leads to a thickening of the heart muscle. And whereas you may want to go work out with weights and develop nice thick arm muscles, although that's a bad idea in orthostasis, you don't want your heart muscle to get thicker and stronger, because it makes it hard for it to relax and fill and do its job. And then the last thing are heart rhythm abnormalities. It can be either, and actually bradycardia, which means a very slow heart rate, is probably the most common of the heart rhythm findings we see in Parkinson's disease, that you just have a slow heart rate. You kind of feel like you're hitting the wall when you go out and start walking, just because your heart rate's not picking up to meet your physiologic needs. It could be severe enough to lead to feeling like you're going to pass out or even passing out. That's sort of the easier one to deal with if it occurs, because we have pacemakers that can solve that problem. Someone once asked me, and I know some of the implantable stimulators that are used for Parkinson's also have a generator implanted somewhere on the chest wall, but you can also have a pacemaker. They don't interfere with each other. But there are also abnormal fast type heart rhythms that can come either from the top part of the heart, the atrium, so what we call atrial tachycardia, or from the bottom part of the heart, which would be the more dangerous place, which is ventricular tachycardia, and that can actually lead to sudden death. And so we do need to monitor these things, look at electrocardiograms and make sure we're not missing anything. And as I mentioned, some of the medications can exacerbate this, because it affects some of the flow of ions back and forth across membranes, which gets a little complicated, but it's how the electrical system of our heart works. Other cardiovascular manifestations that we can see include edema or swelling. Peripheral swelling of the legs is due to venous pooling as a result of autonomic dysfunction. Your vascular bed is not contracting appropriately and returning the blood back to the heart, and some of that fluid seeps out and goes into the soft tissue and gives you that swelling of the legs. We talked about decreased exercise tolerance due to autonomic dysfunction, and a lot of that can be due to what we call chronotropic insufficiency. That just means that the heart rate is not increasing appropriately to meet the needs of the body. And fatigue and shortness of breath. Dyspnea means shortness of breath, or generalized weakness. So I guess sort of the central question is, when should I see a cardiologist? All the time? No, not all the time. Basically a couple of good reasons. Number one, if you're having symptoms, I think anyone who has orthostasis that's more than very mild should probably see a cardiologist, because you may be on the road to requiring medication to deal with that. Certainly, if you have passed out or felt like you were about to pass out, If you're having increased shortness of breath with exertion, or especially if you're getting short of breath at rest or when laying down, when you're supine, or waking up in the middle of the night, kind of having difficulty breathing to the point that you have to sit up on the side of the bed, that certainly warrants a visit with the cardiologist. If your legs are swelling up for no good reason, if you're feeling your heart doing flip-flops, racing, jumping out of your chest, what we call palpitations, probably a good idea to get evaluated. And certainly if you're having any chest, arm, neck, throat, or jaw discomfort with exertion or rest, you need a cardiovascular evaluation. That kind of is sort of all-encompassing, and that's really, outside of those with Parkinson's disease. That's kind of a reasonable short list of who should see a cardiologist. Surveillance and follow-up of cardiovascular manifestations for Parkinson's disease. I think everyone should be checked for orthostasis and for supine hypertension. If you have Parkinson's and you haven't been checked, maybe next time you see a doctor, it's worth saying, hey, would you mind checking my blood pressure laying down, sitting up, and standing up? I want to see if it drops more than 20 points, right? I think everyone should have one of those battery operated blood pressure cuffs, but certainly anyone who's on any medication that can affect blood pressure, you should have some sort of a blood pressure measuring device at home. If you do, go ahead and check your blood pressure, sitting quietly in the evening, and then check it when you're laying in bed. If it goes up more than 20 points, then you have supine hypertension. And that alone, I think, would probably warrant cardiovascular evaluation, just because that is a significant risk factor for developing heart problems down the road. We talked about following the treatment algorithm for orthostatic hypotension. Get rid of the medications that make things worse if you can. Conservative measures for everyone: salt, fluid, binders, don't move quickly against gravity, and then medications if you require them. Screen for structural heart disease if you're having any symptoms or are on any of the medications that are connected with the development of valvular disease, or if you have supine hypertension. Certainly an echo is the easiest thing to do. I put a little picture down there in the bottom right. It's just a sonogram. It's a sound wave picture of the heart. It takes about a half hour. It's very easy. You just rub a transducer on the chest in a variety of different positions, but it gives us a huge amount of information about structure and function of the heart, the valves, blood flow. Really, the single test that probably gives us the most information. And then if you have other risk factors, if you have Parkinson's disease and hypertension and high cholesterol or diabetes, you have a smoking history, a family history, or obesity, I think you should be screened for ischemic heart disease. That's not something you want to miss, because you would be addressed and treated and managed like anyone else with ischemic heart disease. Having Parkinson's doesn't change that equation at all. And then again, if you have any of the above, then you want regular cardiovascular follow-up. Last and not least, I'll leave you with what I started with. Gravity is not necessarily your friend. It's the most prevalent cardiovascular manifestation in Parkinson's disease, orthostasis or orthostatic hypotension. A lot of people get hurt because they just move too fast against gravity. So please be cognizant of that and respect gravity, because it's there and it's significant. And I'm certainly happy to answer any questions if there are some. I'll see if I can pull up the chat as well, so I can see what's going on. There are not a lot. Okay.
We have a couple, or now few.
Should Parkinson patients who don't have a cardiologist obtain one to monitor the potential cardiac issues? So hopefully I answered that with my who should see a cardiologist. But again, talk to your primary care physicians, talk to your neurologists who are working with you in terms of your Parkinson's disease. But if you're worried, one or two quick and easy surveillance kind of tests can be just reassuring that you're fine and you don't have any issues. Is there any correlation between normal pressure hydrocephalus and Parkinson's? The answer is I have no idea. it's certainly not an area of my expertise, and I would have to defer that to your neurologist, so I'm sorry. What is your opinion of cardiovascular exercise with, either with or without orthostasis? As I said, if you don't have any symptoms of orthostasis and you've actually checked, right? Maybe you don't have symptoms, but you're dropping your pressure 20. Think of it this way. If you have a resting blood pressure of 140 over 85, borderline hypertension, and you stand up and you drop your pressure 25 points, right? So you're now 115, you're going to feel fine. That's not going to cause any symptoms. Whereas if you have a resting blood pressure of 105, which is fine, it's great, right? Low risk, but you drop your blood pressure 20 points, you're going to be feeling very lightheaded, like you're going to pass out. So just because you don't feel symptoms doesn't mean you don't have orthostasis or orthostatic hypertension. So I mentioned that simply because that would temper my recommendations about exercise. If you don't have orthostatic hypotension, I think you can do anything you want, especially anything cardio, right? Cardio meaning you're moving, you're exercising, you're running, you're biking, you're swimming, you're walking, your body's moving, because you tend to manage blood pressure much better because your leg muscles are squeezing. It's pushing blood back to your heart. I tend to ask people to hold back from significant isometric exercise, meaning the heavy straining exercise, heavy weights, minimal, reps, low reps, high weights, not good for you in any way, shape, or form, even without Parkinson's disease. High reps, low weights is okay for like toning. Low weights, doing a whole bunch of barbells and moving and keeping your bones and joints in good shape, that's fine. So in general, I would suggest avoiding severe isometric exercise. Let's see where we are here. I'm going to change the question. This imaginary person had a slow heart rate 15 years before PD. Do we think these are related? Okay, so I'm going to try to stay away from answering specific questions about any one person's health, but I can just reiterate that many of the non-motor manifestations of Parkinson's do tend to predate the motor manifestations. Now, slow heart rate, that's very common. It's really common in healthy young people, especially if you exercise. And so it would be very difficult to say whether one thing had anything to do with another. Would Parkinson's explain low blood pressure while increasing exercise load and blood pressure rising as exercise load is reduced? I think any labile blood pressure findings in the setting of Parkinson's can be attributed to autonomic dysfunction, right? Your autonomic nervous system is being affected by Parkinson's in everybody, right? And because Parkinson's is a neurodegenerative disease. And so if you're having weird swings in blood pressure, it's more than likely related to Parkinson's, yes. If a cardiac accident is not available or accessible to a patient, what are the kinds of health professionals could a patient work with outside of their neurologist? Yeah, for many of these things, your primary care physician, you can always start with your primary care physician. And if they feel that you need to be referred to a specialist, whether it's a cardiologist or another specialist, they can manage that for you. So don't not seek medical attention just because you're having trouble getting an appointment somewhere. Copy on what the use of wrist or finger worn devices. Yeah, wearables. I love wearables. Wearables have really made my life easier and have allowed me to make a diagnosis, especially of heart rhythm abnormalities, at a first visit, whereas in pre-wearables, it would take a long time. So when I'm talking about wearables, mostly we're talking about things like the Apple Watch or other devices, or the ring that some people wear, or any of these other devices, the cardio smart thing that is external to you. But what it does, but you have to be careful because a lot of times they're going to give you false alarms. And a lot of patients come in really concerned because my Apple Watch told me my heart rate's too slow, or my Apple Watch said I'm an AFib, and they're not, because the Apple Watch doesn't know the difference between frequent premature atrial complexes and atrial fibrillation. So, but they're very helpful because on some of the wearables, you can actually record the electrocardiogram, and it gets saved to your phone, and you can print it, you can email it in, or you can just show it to your doctor when you go to your office visit, and I can make the diagnosis. You know, so often patients come in with palpitations, you know, a feeling of an irregular heart rhythm, or my heart's racing from time to time. You know, I can put monitors on them from now until yin yang, and unless we happen to have a monitor on the patient when they have their symptoms, I'm not going to see anything. Yet, if you have a wearable device and you're having symptoms and you just kind of do your thing, you've now recorded it. And so I'm a big fan of wearables. I hope that answers your question. Do you recommend a chemical stress test versus treadmill stress test for someone with Parkinson's? So there are a variety of different types of exercise testing that we can do. And that depends on a lot of factors. And Parkinson's will not be one of those factors unless you have significant motor issues that prevent you from walking on a treadmill. If you're not able to exercise enough on a treadmill to make it a diagnostic study, we can do what we call pharmacologic exercise testing. That's when we give you a medication intravenously through an IV that makes your heart think you're exercising, but you're not. It doesn't really make your heart think you're exercising. What it does is it dilates your coronary arteries and increases blood flow to the through normal arteries, and then we can see the difference with abnormal arteries. So there are a variety of different types of exercise tests. There's plain vanilla treadmill, just you and your electrocardiogram and symptoms. A lot of false positives there, especially in women. I like to combine it with some sound wave pictures with an echo, which increases the sensitivity and specificity of that study. We have nuclear imaging studies, either with a treadmill or a pharmacologic study. And then we have PET-CT, which is the most sensitive and specific. So there are a lot of reasons that we would choose one test over another. Some of it relates to your symptoms, your resting electrocardiogram, your ability to exercise, and what else we know about your heart. So it's a loaded question without a simple answer, but a cardiologist is really best equipped to make that recommendation for what type of an exercise test would be best for you. I have sleep problems that throws me off my PD symptoms and medication timing. I have a PD for 20 minutes, just taken off of blood pressure meds. Okay, we're getting into a very specific question. And I'm gonna bail from this question because it's a little bit too, and I'm not criticizing. It's just I really have to try to stay away from giving any personal medical advice in these kinds of presentations. All I can simply say is if you have concerns, you've had problems, you know, appropriately managing some issue, follow up with your doc. If you don't feel like you're getting you know, an adequate response, then move on to a specialist and get a second set of eyes on the problem, because that can sometimes be very helpful. I think I've gotten through all of the questions there. I don't think I missed any, David. I don't know.
No, all of the questions in the chat have been answered. Dr. Levy, we'd like to thank you very much for your time and for a very informative presentation, which I'm sure is stimulation for thought on the part of many of the people who are in attendance. It probably will educate them in a way that they know how to ask some intelligent questions of their PCPs, and if they have a cardiologist, of their cardiologist. And I think anybody who wants a copy of the slides is welcome to send a request to info@parkinsonsocialnetwork.org, and we will in fact send the PDF of the slides out to them.
David, just in case someone might have a question but can't use the chat, can you wave your hand? Can we do that before?
Yeah, let me
Dr. Levy go?
remove the spotlight from Dr. Levy just so that we get a chance to see the entire group.
All right, gotcha. And then yeah, it's on gallery. So I'm just making sure anybody had their camera on and they want to ask a question but can't type it. You know, we do have everyone muted, so Just wave your hand and we'll see. Okay.
John waved his hand.
Yeah, let me, I just asked you to unmute, John, so let's see. Oh, try it again. To unmute yourself. Oh, I think you'll have to click it again. One more time with feeling.
There you go.
I was just asking for a copy of the slides.
Oh, okay, John, we'll put you on the list. Gotcha.
Yeah, you know, again, the one thing I would just stress the most, and you all know this, but you know, you just have to be careful. You know, you are just at such risk of falling and hurting yourselves. And you know, it's not just the motor issues, it's these blood pressure issues as well. So just you got to be careful. You have to just be respectful of gravity, because you know, it's always going to move you in the wrong direction. And so please, you know, the last thing you need is a hip fracture.
Carol, I see you waving your hand, and I just asked you to unmute, so go ahead.
Hi, I just wanted to comment that thank you, David, for getting me into this with the link. And I had orthostatic hypotension, and in 1 year I had passed out about 5 times. But the doc changed me from the regular levodopa to a time release levodopa, and it all went away. I haven't had an episode. I haven't passed out in a year. It's been great, just by changing the timing of how quickly I got the stuff. So thanks to my doc.
Yeah, that's encouraging. And, you know, as I mentioned, that is the main culprit. You know, levodopa is the main culprit that makes orthostatic hypotension worse. And that's a happy ending. That's great.
Thank you, Carol, for sharing that. Anybody else? I think that's it, Dr. Levy.
All right. Well, thank you very much. I'm very impressed with your organization, what I've learned about it from David and Nancy.